So many thanks everyone for being here today, and also to the Closer team for the opportunity to share this work. This study investigates the gendered impact of COVID-19 on health behaviours and changes in the protective effect of health behaviours on mental health in the UK. This study is joint work with Paul McNamee at the University of Aberdeen and Sylvia Mendolia at the University of Turin. We would like to thank the Rural and Environmental Science and Analytical Services Programme of the Scottish Government for funding awarded to the University of Aberdeen, which enabled this work. As we know, health behaviours play an important role in health and well-being. In particular, diet, alcohol consumption, and physical activity are closely linked to mental health. In terms of diet, a number of studies, including RCTs, show that the consumption of fruits and vegetables can improve mental health and buffer against clinical levels of distress. The link between alcohol consumption and physical activity and mental health is also well established. Despite the benefits of healthy behaviours, a significant proportion of the population in the UK report unhealthy behaviours. Typically, women report a higher consumption of fruits and vegetables and lower alcohol consumption. On the other hand, men tend to report higher physical activity. There is considerably less evidence on gender differences in the psychological benefits of health behaviours and how this protective effect changes during shocks. The COVID-19 pandemic likely impacted health behaviours and possibly also the link between health behaviours and mental health. The UK experienced a large number of cases and deaths in the early part of the pandemic between March and May 2020, which also saw the first national lockdown, denoted by the shaded area over here. Subsequently, there was a smaller spike in November 2020, leading to another lockdown and a huge spike in cases after the Christmas holidays, resulting in a third lockdown. In March 2021 onwards, the number of cases began to taper off after the vaccine was rolled out towards the end of 2020. The lockdown was subsequently lifted in stages. There has been quite a bit done looking at the impact of COVID-19 on health behaviours in the UK, especially focusing on the early part of the pandemic. Prior studies based on the initial periods of the pandemic typically find significant heterogeneity in that some individuals adopt positive or the same behaviors while others move towards negative behaviors. Studies based on the later part of the pandemic find poorer health behaviors on average. This makes sense based on the graph I showed you earlier, where the greatest impact of the pandemic was really in the beginning of 2021, so in the latter part of the pandemic. In general, being female, having a poorer socioeconomic background, reporting poorer pre-pandemic behaviors, and higher levels of stress, boredom, loneliness, and distress were associated with poorer health behaviors. A number of studies have now shown that the COVID-19 pandemic had a greater impact on women, and due to this may have adversely impacted their health behaviors to a greater extent than for men. First of all, women with children shouldered more responsibilities on top of home working during the pandemic. Women spent more time on housework, childcare, and homeschooling, which may have reduced the time and energy they had to invest in or maintain health behaviors. There is also evidence that women experience higher cognitive labor during the pandemic. Cognitive labor here includes anticipating, organizing, managing, and evaluating the decision-making tasks of housework and childcare. Women also experience greater levels of psychological distress compared to men. This gender gap in psychological distress was particularly pronounced among younger women and largely explained by experiences of loneliness. While greater housework, childcare, and homeschooling were not the main mechanisms, there was moderate evidence that these factors also resulted in worse mental health for women with children. There is also evidence that greater engagement with cognitive labor and compliance with social restrictions increase distress levels among women. There is a large literature, of course, showing that greater levels of psychological distress can lead to worse health behaviors as a way of coping with heightened distress. Further to changes in health behaviors, it is possible that the link between health behaviors and mental health changed differentially by gender during the pandemic. This could be due to adverse changes in health behaviors, but also a reduction in the protective effect of health behaviors on mental health. Thus, the study has two research objectives. Firstly, we would like to understand the effect of the pandemic on gender differences in health behaviors. Second, we would like to understand how the pandemic changed the link between health behaviors and mental health by gender. In other words, we would like to assess whether the protective effect of health behaviors on mental health differed by gender before and during the pandemic. In this study, we utilized a longer time span to present a more comprehensive picture of how health behaviors change throughout the course of the pandemic, covering all lockdown periods up until March 2021. Prior studies typically only focus on particular stages of the pandemic, which may limit our understanding of the overall impact of the pandemic. For example, individuals who initially exhibit poorer health behaviors may compensate for this in later stages of the pandemic. We also use a comprehensive set of information on the consumption of fruits and vegetables, physical activity, and alcohol consumption, and assess effects associated with aggregate measures of these health behaviors. Finally, we assess gender differences in the link between health behaviors and mental health before and after the pandemic in the UK, which has not been done yet using a clinically validated mental health measure. The data used for this study is from the UK Household Longitudinal Study, which is also known as Understanding Society. It is a panel data set that has followed over 40,000 households in the UK since 2009, with interviews conducted every 2 years. It contains extensive information on socioeconomic characteristics, health behaviors, health outcomes, and other factors over time. The main study of the dataset contains the main data for understanding society and is what we primarily use in this study. During the pandemic, Understanding Society ran the COVID-19 study between April 2020 and September 2021 to understand the effects of the pandemic. The COVID-19 study was run monthly up until July 2020 and then bi-monthly, with the last data collection conducted in September 2021. Unfortunately, health behaviors are not captured in every wave of the COVID-19 study. The only time we observe all the health behaviors we look at is in January 2021, which limits our ability to understand the overall effects of the pandemic on health behaviors and associated mental health impacts. While we use data from the main study in our main analyses, we also assess how our results change when using data from the COVID-19 study. Specifically, in the main study, we compare outcomes between men and women in waves 7 and 9, collected between 2015 and 2019, to outcomes in wave 11, collected between January 2019 to May 2021. For wave 11, we exclude all other waves as the health behavior variables. For wave 11, we exclude observations collected before March 2020, and we also exclude all other waves not mentioned here as the health behavior variables were not collected in these waves. In our analysis, we look at 3 key health behaviors. Understanding Society asks questions on the frequency that fruits and vegetables are consumed in a week and subsequently the number of servings per day. Based on these questions, we have 3 binary variables. The first 2 measure whether the respondent consumes fruits and vegetables at least 4 days a week versus less than. The third variable captures whether the respondent consumes at least 5 servings of fruits and vegetables a day based on the 5-a-day recommendation from the World Health Organization. Questions are also asked on whether the respondent engages in moderate to vigorous physical activities and walking and the time spent on these activities. Based on these responses, we create a binary variable to denote whether a respondent engages in at least 600 metabolic equivalent task minutes of physical activity versus less than. This cutoff measure is based on guidelines from the World Health Organization. Now, these guidelines actually exclude walking, but we include this as evidence shows an increase in walking over other activities during the pandemic due to social restrictions. In robustness tests, we also assess how our results change when we exclude walking from the analyses. Alcohol consumption is measured based on the audit C, which is a commonly used instrument to measure the frequency and intensity of alcohol consumption. From these responses, we create 2 binary variables. One to denote whether a respondent drinks less than 2 to 3 times per week versus more than, and whether they binge drink less than weekly versus more than. In all these variables here, 1 denotes a positive behavior and 0 otherwise. From these 6 variables, we create a healthy lifestyle index, which is the sum of positive health behaviors ranging from 0 to 6. We also create a healthy lifestyle indicator, which equals 1 if the respondent reports at least 4 positive health behaviors, so a majority of positive health behaviors. In our study, we emphasize results for the aggregate health behaviors, partly to address concerns on multiple hypothesis testing, and also due to the fact that individuals typically exhibit a mix of healthy and unhealthy behaviors. Mental health is assessed using the General Health Questionnaire 12, the GHQ-12, in every wave of understanding society. The GHQ-12 is a clinically validated tool. Respondents are asked questions on their general happiness, confidence, and capacity to face problems, overcome difficulties, make decisions, and enjoy their day-to-day activities over the last few weeks. In our main analyses, we use the Likert score, which captures more variation in mental health. This score ranges from 0 to 36, with higher scores indicating worse mental health. In additional tests, we also assess the sensitivity of our results using the Caseness score, which ranges from 0 to 12, and also the cutoff score to denote risk of clinical levels of distress. In terms of the methodology, for the first research question, we would like to compare the health behaviors of men and women before and during the pandemic. To do so, we use a difference in differences model. What we are doing here is basically comparing pre and post outcomes and between men and women. Our main coefficient of interest is on this interaction term, interacting an indicator for the pandemic period and gender. We control for ethnicity, region, age, educational attainment, and month effects to account for seasonal effects in health behaviors. So this is our base model. We also estimate separate models with gender-specific linear trends to account for existing trends and outcomes between men and women, a gender-age interaction to account for differences in trends between men and women by age, and individual fixed effects to account for time-invariant observed and unobserved factors. In our analyses, the coefficient on the interaction term will be driven by changes in health behaviors among women as well as men. For example, a negative coefficient could be driven by declines in health behaviors among women, but also gains in health behaviors among men. In our second research question, we would like to understand whether the relationship between mental health and health behaviors changed differentially for men and women after the pandemic. We utilize a similar difference in differences model where our outcome is now mental health. We estimate this equation here separately for men and women. Following other studies that investigate the relationship between mental health and health behaviors, we prioritize the individual fixed effects estimation here. We include the same set of controls in the previous model. In this case, we have 3 coefficients of interest. Beta 2 captures the relationship between mental health and health behaviors before the pandemic. Beta 3 captures the effect of the pandemic on this relationship. Beta 2 plus beta 3 then captures the relationship between health behaviors and mental health after the pandemic. A quick look at descriptives. In Table 2, we compare unadjusted means by gender for the health, behavior, and psychological distress variables before and during the pandemic. Consistent with other studies, women report better overall health behaviors than men. For example, before the pandemic, 70% of women reported at least 4 health behaviors compared to 56.7% of men. We see that despite changes in health behaviors during the pandemic, women are still more likely than men to report better levels of overall health behaviors. It is important to note here that our analysis focuses on changes in health behaviors and not levels. We are comparing the changes in women's health behaviors to changes in men's health behaviors attributable to the pandemic. Let's look at the results. Figure 1 provides results on the differential effect of the pandemic by gender. Based on graph A, which presents estimates from the base model, women reported worse changes in health behaviors compared to men during the pandemic. Women were 3.2 percentage points less likely to report at least 4 health behaviors compared to men during the pandemic. They also reported 0.09 fewer health behaviors. Both these effects are significant at the 1% level. The adverse effect of the pandemic on changes in health behaviors among women is largely driven by a significant decrease in the consumption of fruit by 2.2 percentage points, increase in the frequency of alcohol consumption by 1.8 percentage points, and increase in binge drinking occasions by 4.3 percentage points. These effects observed for the aggregate measures are robust to the inclusion of gender-specific trends, gender-age interaction, and individual fixed effects with minor differences in changes for specific health behaviors here. Next, let's look at how the link between health behaviors and mental health changes for men and women. Based on Figure 2, there is a large statistically significant relationship between mental health and health behaviors among women before the pandemic. So this is what we would expect. We observe this relationship for all the health behaviors except for the frequency of alcohol consumption. In terms of the overall health behavior measures here, adopting a healthy lifestyle is associated with a 0.61 points decline in the GHQ-12 Likert score. So this implies better mental health. Each incremental health behavior is associated with a 0.34 points decline in the score, and both of these are significant at the 1% level. However, during the pandemic, the associations between most of these health behaviors and mental health weaken or disappear, except for the frequency of alcohol consumption and binge drinking. Importantly, the association between mental health and the healthy lifestyle indicator completely disappears during the pandemic. This on its own may not be so surprising, but it is striking when we compare it to the results for men. Based on Figure 3, we also see a strong statistically significant relationship between mental health and health behaviors among men before the pandemic, albeit to a lesser extent than what we observed for women. During the pandemic, the associations between mental health and health behaviors generally increase in magnitude, but these differences are largely not significant. Thus, while the pandemic is associated with a lower protective effect of health behaviors on mental health for women, this protective effect remains unchanged for men. Importantly, while the protective effect of health behaviors is stronger for women before the pandemic, it is stronger for men during the pandemic. An important challenge to these mental health results is potential reverse causation and whether poor mental health among women during the pandemic is really driving these worse health behaviors that we are observing. To see whether this might be the case, we repeat our estimations for the first research question separately for observations that report psychological distress and those that do not. The logic here is that if poorer health behaviors among women during the pandemic were purely driven by psychological distress, then we should not see negative changes in health behaviors among those who report no psychological distress. Okay, so the third column is really of interest here. Interestingly, what we find is that poorer health behaviors among women are largely present in the sample without psychological distress. So this here provides evidence that psychological distress is not driving the poorer health behaviors that we observe. But of course, we cannot completely refute this bidirectional relationship between health behaviors and mental health. To conclude, our study finds that the pandemic worsened health behaviors among women compared to men. In particular, women are 3.2 percentage points less likely to adopt a healthy lifestyle compared to men during the pandemic. These results are robust to controlling for gender-specific linear trends, gender age trends, and individual fixed effects. Results are also robust to using data from the COVID-19 study, employing the GHQ-12 caseness continuous and cutoff measures, and excluding walking as a physical activity. With regards to findings on the first research question, we also repeated our base model with a more detailed list of controls that may have also changed during the pandemic, and we find that these adverse health behaviors that we observe among women continue to persist with a detailed list of controls including income, employment, household characteristics, marital status, and so on. Importantly, we observe a reduction in the relationship between mental health and health behaviors for women, but not for men, suggesting that women derive less psychological benefits from health behaviors during the pandemic. I'd be happy to take any questions.